we have structured this such that we're going to present a couple of cases and get some feedback on how you would manage the cases, and out of these cases will come a topic which we'll discuss. So, I'm presenting the cases, and they were both my cases, and they both had unexpected outcomes, so you can talk to me about that if you'd like. And Morgan's done the heavy lifting, is going to be doing the talk on the topic that comes out of the cases. So the first case I want to discuss is that of a 25-year-old woman who presented last summer, and she called an ambulance because she had a rather sudden onset of sharp left lateral chest wall pain. She had been seen at a walk-in clinic a couple of days ago and diagnosed with a viral illness. She had had sort of a sore throat and that sort of stuff. These are the notes right from the ambulance call report. But since that time, she had increased pain. It was pleuritic pain, increased with inspiration and to touch. They documented her heart rate at 130, her respiratory rate at 18, her blood pressure 133/78, and O2 sat of 100%. The triage nurse, I noticed a couple of nurses hiding in the background there, said their documentation was for left chest wall pain, diagnosed with a viral infection a couple of days ago, and the pain was increased, and vital signs were similar to what had been documented by the ambulance, except the temperature's documented here at 39.4. Okay? So the doctor's note, that would be me, had a 25-year-old with fever, chills, left lateral chest pain for 2 days, had a sore throat earlier in the week, went to a walk-in clinic, was diagnosed as a viral illness, past medical history is normal on oral contraceptive pills, no allergies, heart rate 120, temperature 39.4, faced flush, throat normal, mild adenopathy, chest was clear. So I guess I want to pick on the residents and find out where you think we should go with that. Kate, that's a nice smile for this time of day. So, knowing smile. So here we've got 3 pretty much consistent histories from ambulance to nursing to physician. Is there any more information you'd like to know?
I'm just wondering, the 100%, was that a room air sign?
It was on room air.
Okay. And otherwise, like, does she look well?
She looks, her face is flushed. She is alert, attentive. She's talking to you. She looks a bit tired, but she doesn't look sick from the foot of the bed test.
And she otherwise is healthy?
Perfectly healthy.
No other DVT, PE risk factors?
No other DVT, PE risk factors, no.
Okay. So she sounds to me to be, she's probably more unwell than the run-of-the-mill 25-year-old viral illness. I'm concerned, she actually has a few service criteria. Concerned she could have an infectious process like pneumonia would be top of the list. With this pleuritic sounding pain, this question of thromboembolic disease might be sort of somewhere in the back of my mind. Yeah. But I'd probably start with some basic blood work and a chest x-ray, give her some fluid, some Tylenol, try to get her heart rate down and see if she perks up a bit.
Can you define basic blood work for me? Like, what is that?
So I would send, a CBC, electrolytes, urea, and creatinine.
Okay. Does anyone want to, you mentioned DVT-PE, does anyone want to go there? Does anyone want to do blood work to look for PE in someone like this? And why not? Samir?
Pre-test probability is low currently, so I wouldn't go down that road unless I've exhausted other diagnoses.
Okay. So she had some blood work done. A lactate was not drawn. When I saw her, she didn't really look all that sick. And this blood work had been done prior to my seeing the patient. So I did not add a lactate on because this blood work was available by the time I actually saw her. And white count was 11.3, sodium unremarkable, bicarb was 24, so I wasn't concerned that she had a metabolic acidosis, which is why I didn't add on a lactate at that point. Cultures had not been drawn at that point. So from there, we did a chest x-ray, just as Kate suggests. Based on her symptoms, I thought that she had an infiltrate there. It's not that apparent on the lateral, but it came down and touched her diaphragm, and I diagnosed her with left lower lobe pneumonia. And the radiologist agreed, okay? So good for me. Okay, so what are you going to do next? Work? let's say you reviewed this with your consultant, and consultant, that's a pneumonia, easy, that's a pneumonia. 39.4, heart rate of 120.
So I would continue with K-Stream, which is fluid and antipyretics. I'd also start some antibiotics at this point in time.
Yeah. What would you give for an antibiotic, and how?
So I'd probably use an oral antibiotic. I feel like she's going home by accident.
Put her on some clarithromycin. Okay. So the management that I had done there at the time, and this was actually started before the x-ray was done, because I thought clinically she must have pneumonia with that viral prodrome and the high fever. And so given her a liter of fluid because she was tacky, got her temperature down with some ibuprofen, and I gave her a dose of azithromycin. You could use clarithromycin as well as first-line management. Reassessed her a couple hours later. She felt better. Heart rate was down. Her temperature was down. She wants to go home, and her biggest question is, this is a Saturday. Her biggest question is, we are going on our honeymoon on Thursday. Am I going to be able to go? They're going to the Caribbean. It's a delayed thing. And I said to her, the great likelihood is you're going to feel a lot better within a couple of days. And if that's the case, there's no reason that this should impact upon your honeymoon. And so the fact that I said that actually ruined everything. So 4 days later, she comes back. And her pain has continued. In fact, it's worsened. She's felt nauseous, probably from the medication I prescribed. Her cough was now productive, and she had, in the last 24 hours, had increased shortness of breath. Temperature at presentation on that time was 37.6. Her respiratory rate was significantly higher than before at 28, and her O2 sat was down to 92% on room air. She had decreased breath sounds in her left chest. White blood cell count was 21.3. Okay, so that's her chest x-ray 4 days later. All right. What do you think, Justin?
Certainly abnormal.
Okay. Full marks.
So obvious findings that on the left chest, it's almost entirely opacified with very little air remaining there, and it looks like essentially a massive pleural effusion on the left side, and there could be a little bit of push basically toward the right side just from this mass effect.
Okay. So what would you think? What would you want to do with her now?
Well, obvious things. I mean, she certainly needs a septic workup, and she is looking septic, and with the blood work and everything like that, she needs broad spectrum antibiotics at this point in time. She needs to be admitted. There's just this. I'm not sure if this is a loculated effusion versus just free flowing effusion. So she probably needs a CT, to be totally honest, and likely needs a chest tube to drain.
So this is a young person who's evolved from a small left pleural lobe infiltrate to this massive effusion, and is much sicker. So she was referred on to respirology, put a chest tube in that produced the stinkiest fluid you'll ever experience, which is that of an empyema, and was diagnosed with group A strep. And she had a chest tube in. She was admitted for a couple of weeks, was home for 2 days, and worsened and came back. So she spent basically a month in hospital with this thing resolving on some, I think they initially put her on Piptazo when she first came in, and then when it grew group A strep, they added penicillin into the mix, which worked well. Laura?
On that first visit, you saw her when she was going home. Had her vital signs pretty much normalized by that
Her
point?
heart rate was down. Her temperature was normal, 36.6. Her heart rate was 109 at discharge. So she was still a little bit tachycardic. I've looked at this case backwards many times, and I'm thinking. So the question I put forward: Would anyone have done anything different? Make me feel good. Would anyone have done anything different on that first presentation other than treat her with outpatient antibiotics? All right, well, let's think about that for a second as we go on to the second case. And that's another young person, a 21-year-old male university student from Western. He called the ambulance around 5:30 in the morning because he had 4 days of fever and weakness, had just basically felt unwell, and then awoke with some sharp left-sided chest pain. Their notes were he had productive cough and dehydration despite increased fluid intake. His heart rate was 120, O2 sat was normal, temperature was documented by biochems at that time was 38.8. Triage nurse, essentially the same findings, very similar vital signs. And I had a medical student working with me on the 4 to 10 a.m. shift, and she had documented sharp pain, 4 days of fever, said been using some Tylenol, commented on his urine being dark. Woke Woke up at 4 o'clock that morning with sharp left-sided chest pain, with no nausea or vomiting. His cough was productive of clear sputum. Had upper respiratory illness types of symptoms a week ago, but which had resolved. And the vitals were documented, but the heart rate had actually come down to 90 by the time that he had been settled and seen. She documented the chest was clear with a tender left chest wall. So where are we going to go with this one? Justin?
So for him, I give him IV, give him some fluids, some Tylenol. I would get blood work on him, so CBC, uric creatinine, glucose. I would actually maybe think about doing a quick ultrasound to look at his heart, see if there's small fusion, maybe an ECG, look for pericarditis with the kind of radiating to his left shoulder there. Seems kind of different, and a chest X-ray.
Okay. All right. Now, is that so? Would you do the ultrasound as a routine, or would you do that if other investigations weren't panning out?
I'd do it as part of my physical exam.
Part of your physical exam. Okay. All right. I didn't do that. All right. And so, in terms of management, you want to give IV fluids, and anything else?
Antipyretic.
Antipyretic. Okay. Would you want to initiate any antibiotics?
Not yet. I wait for the chest X-ray to come back. If he's non-respiratory distress and maintaining sats without oxygen, I'd probably hold off until I get a chest X-ray confirmation.
Okay. So we did basically that, although I gave him a dose of Levaquin as well at that time, and asked for them after blood cultures. The student had ordered some blood work. I added blood cultures and a lactate onto him. This case happened about a month after the other girl. So I wasn't going to miss this one. This one I was going to nail to the wall.
I would suggest that this patient in many hospitals would get a chest X-ray, maybe some IV fluid to start with, and the same with the previous patient. Quite possibly no blood work, maybe some IV fluid and some antipyretics.
Right.
But not necessarily all this blood work.
Now, having said that, both patients do have criteria for sepsis, right? And so with criteria for sepsis, you should be looking towards goal-directed therapy and doing the blood work and lactate and stuff. Yeah.
Just curious, because I'm always harping on the residents, I'm sure they'll tell you about it, but your choice of intravenous levofloxacin there over
5 in the morning, 5:30 in the morning, my brain's not working right. Not necessary. Certainly you could have used a dose of oral antibiotics in him. He had been complaining a bit of nausea, but you could have certainly used oral. And you did. When I looked at this after the fact, I thought, didn't even really need to give Levaquin. It could have given a macrolide on this guy as well. I mean, really, there's no indication for him to have quinolone.
And just if people are not aware, the reason I harp on it, because a single dose of PO Levaquin is like $2 and change, and a single dose of IV Levaquin is like $80.
So here are his blood work results. White blood cell count 23.9 with moderate left shift, but no immature forms. Normal hemoglobin, normal electrolytes, normal urea, glucose, lactate 0.8. We did a urinalysis because of the dark urine. It was normal, including the specific gravity. So then we did a chest X-ray. Sean, what do you think of the chest X-ray?
Well, that's definitely abnormal on the left side there. There's sort of an infiltration kind of on the left lung field.
Okay, so where, and just help us understand where in the lung that is.
Looking on the lateral, I'd actually have to say it's probably the lower aspect of the upper lobe.
Right. So this is a left upper lobe infiltrate. Now, after I looked at it sort of for the 50th time, I thought, I wonder if there's a little something in the superior segment of the left lower lobe as well. Maybe more than one lobar involvement, but it doesn't really change much for me in terms of management. So that's the chest X-ray. So, diagnosed with left upper lobe pneumonia, feeling good about myself, wasn't going to mess up this time. Reassessed him, he felt better. Heart rate was 87. Temperature 37.2, check. O2 sat 96%. Okay, not award-winning, but we're gonna run with it. It's certainly within the realm of normal. So I discharged him home on Levaquin. After 3 days, he's not getting. Sorry, question, John?
Is what time of year is this happening?
This was in September. This was mid-September.
Has he been traveling anywhere?
Why do you ask that question?
Well, because it's an M&M kind of situation. Maybe I'll let it go.
He had not been outside of the province.
No, I think I know this case, so I'll just keep my mouth shut.
Are you reviewing it for a lawyer? Okay, we'll talk. Maybe we can talk afterwards. You are, aren't you? No. He was taken to hospital at Oakville Trafalgar and admitted for IV antibiotics. Still was not improving, and I've got a series of X-rays that I'll show you. So a respirologist was consulted who did a bronch, did some washings, looked at it in the microscope by pathology. Nothing was isolated. They tried every combination of antibiotics they could think of. Really wasn't getting any better. So a pathologist said, I'm going to take another look at those washings, and saw some spores of Blastomycosis. Treated with amphotericin and improved within 72 hours. So here was his chest X-ray, September 23rd. Thank you, Morgan. And then there's, after 2 or 3 different types of antibiotics, there's September 26th. And you can see that there's definitely involvement in the right lung now as well. If you look at the right upper lobe, there's some infiltration. Even worse on October the 3rd. So it's really infiltrated his entire lung. And then the one on October 14th is after about a week's treatment with amphotericin. So he was diagnosed with blastomycosis, and he had been working, traveling in northern Ontario for summer, had been planting trees, is what he'd been doing. So this round is not about blastomycosis. It's about something different, but I thought I'd just give you 2 seconds on blastomycosis because it's not something you'll see very often, and it may not be something that you'll see, other than today. But it's a slow-growing spore, and it has got fairly significant geographic distribution in Ontario. The sort of the reddish-orange U-shaped pattern that surrounds the Great Lake is where blastomycosis exists. And this slide's not going to project very well in terms of the numbers. The highest incidence of blastomycosis is actually in the Toronto region, but this is at 66 per 100,000. That's not because there's a lot of blastomycosis in Toronto. That's because there's a lot of people in Toronto who have been elsewhere. But you see up in the east region, the central region, 14 and 10 cases per 100,000 is the incidence of it. It's got a non-specific clinical presentation. Interestingly, usually affects immunocompetent hosts. It can go anywhere, but pulmonary presentations are the most common. It's often mistaken for tuberculosis or bronchogenic CA based on initial chest X-ray. It takes a long time for it to come on. It takes sort of 30 to 60 days from the exposure until the time that people become symptomatic. So what we're going to talk about today is pneumonia in young healthy adults. And before Morgan gets up, the question that I want to ask consultants is what are the things that you use to decide whether or not someone can go home, can be discharged from the hospital when you've diagnosed them with pneumonia, and what are the indications for them to be admitted to hospital?
So usually you use vital signs and just sort of a gestalt of how they look, and in both cases, the patients that you saw, I would have sent home with good discharge instructions, as I'm sure you did as well. So I would be in the same boat as you.
So who would you keep? Let me ask you that.
Who do I keep? Somebody whose O2 sat requires oxygen, somebody's tachycardia that won't go away, or somebody who has, impressive chest X-ray who may have quasi-normal vital signs but looks awful. But again, that's a gestalt, and that's the last one I said is a harder sell to any service.
Drew?
Yeah, I think it's probably similar. I mean, you keep the abnormal vital signs, excluding the mild tachycardias, I think. Obviously, people that are septic, immunocompromised, but in the young, healthy person, the only thing that I think I refer more is the impressive pneumonia or multilobar pneumonia involvement. I refer those. Even parapneumonic effusions, I just arrange urgent follow-up for. I don't bring them in. I don't think I would have done anything different on either of your cases.
Certainly in the kid with blastomycosis, it was a pretty impressive infiltrate, and it made me think, is this kid going to be able to go, or do they need to stay for a day or two? But when he was reassessed and his vital signs had normalized and he was feeling better, what
are you going to do in hospital?
Right. So the drug of first choice is still a macrolide. Kelly, who do you tend to keep in hospital?
I had a 40-year-old with a sat of 89 and pneumonia this week that I was able to convince them to keep. But the multilobar ones bother me too. But if they're saturating okay and they're usually some fluid and antiemetics and the nausea issue is gone. They feel better, then I send.
Does anyone use scoring systems?
The young ones usually don't make it.
One thing we haven't talked about is age and comorbidities, and they factor significantly, I think, into the decision as well. Certainly if they're diabetic, certainly, well, you're not going if they COPD, they're not going to be statting normally. I can't think of anything off the top of my head, but certainly in age, I mean, if you saw this in a 75 or an 80-year-old,
Sure.
you'd be much more inclined to admit, and I suspect, and that fits into the scoring system that I don't use either.
A lot of times it's social reasons too.
Sorry?
Social reasons a lot of times too, as
Sure.
for any patient.
Absolutely.
Your scoring system doesn't get you there on the young, healthy people.
Yeah.
Unless you're sick, you already know that.
Right. So which scoring system do you tend to use?
Well, there's the Curb 65 and the, well, whatever the other name is for the other one that's posted downstairs. But again, I find it relatively useless because you've already made that determination, and that just gives you a number if you want it. But
Right.
I don't find it ever helps me in young, healthy people.
Okay. All right. So I'm going to hand it over to Morgan now, and she's going to talk about pneumonia and sort of we're going to focus a bit of time on studies that look at predictive scoring systems and how useful they might be in young people or not.